Okay, let's dive into something complex but really, really important today. What happens when someone's already dealing with, well, the challenges that come with getting older,
Yeah.
maybe some memory things, moving a bit slower, maybe a whole list of medications.
Right.
And then on top of all that, a serious new diagnosis lands, like cancer.
It's a scenario a lot of families face, unfortunately. And navigating it requires, well, a really careful balancing act.
It really does. And our source material today gives us a fantastic window into exactly this challenge. We're looking at a specific case study.
Yeah, a really detailed one.
We're going to deep dive into the story of an 82-year-old gentleman, let's call him Mr. B, in the source, who's facing a new active cancer diagnosis, multiple myeloma.
Right, which had been sort of quiet before, but now needs treatment.
Exactly. And he's dealing with this right alongside several other health issues, those sort of typical age-related conditions.
Geriatric syndromes, yeah.
So we'll unpack the medical thinking, the human side of it, and really what it takes to figure out a path forward when things are this complicated.
Think of it as getting the key insights into geriatric oncology without needing the medical degree. It's about seeing the whole picture.
Absolutely. Looking at the whole person, not just the latest diagnosis.
And the source does a great job. It takes us right inside the geriatric oncology consultation for Mr. B. You see that comprehensive approach in action.
Okay, so let's paint the picture. Mr. B, 82 years old. He has multiple myeloma. It was smoldering before, kind of lurking.
Present, but not causing major problems, yeah.
But now it's progressed. It's active. Needs treatment. And the oncology team is thinking about a pretty significant regimen. Looks like lenalidomide, dexamethasone, and daratumumab. Heavy hitters.
Right. And the fact that they even requested a geriatric oncology consult, that tells you something straight away.
That it's not straightforward.
Exactly. It signals they need help assessing his overall fitness for that kind of treatment. Because like you said, he's got these other geriatric syndromes going on.
Things that can really affect how someone tolerates tough treatments.
Precisely. Resilience, response to the stress of therapy.
Yeah.
It all gets complicated.
And something that jumps out immediately in the source material, Mr. B didn't go to this important consultation alone.
No, he had his daughter and son with him, both described as highly involved.
That's huge, isn't it, that family support?
Invaluable. Absolutely critical in these complex situations. And their perspective, their worries, were clearly a big part of this consultation.
So what were their main concerns, according to the source?
Well, at top of the list, honestly. His thinking, his cognition.
Okay.
They were seeing memory problems, especially short-term stuff, forgetting appointments, needing things repeated over and over.
And this wasn't just a vague feeling, right? He actually has a diagnosis.
Yeah, a formal Alzheimer's diagnosis from 2021. And the family shared this really striking example.
The one about his brother.
That's the one. He failed to recognize his own brother by name until he physically saw him.
Wow, that really hits home, doesn't it?
It does. And interestingly, his son mentioned that a particular medication, mirtazapine, seemed to help his engagement and maybe his cognition a bit in the past, something they'd observed.
Okay, so cognition was number one. What else?
Mood was another big one. He apparently has a long history of chronic depression, dysthymia, they call it.
Like a persistent low-grade depression.
Exactly, going way back to his youth. The family felt the Alzheimer's was making it worse, and he was still feeling pretty down despite being on an antidepressant, bupropion.
And they mentioned mirtazapine again here.
Yeah, they felt it had helped his mood before, along with sleep and appetite, so that was on their minds.
And then just the sheer number of medications he was taking.
Oh yeah, polypharmacy, that was definitely a worry for them. All those pills, potential side effects, drug interactions.
It's a lot to manage.
A lot. And they specifically asked about one drug he was taking for urinary incontinence, Myrbetriq. They wondered if its anticholinergic properties might be adding to his cognitive fuzziness.
Right, those anticholinergic drugs can sometimes affect thinking, especially in older adults.
Exactly. And they also remembered that the mirtazapine, while maybe helpful for mood, had made him dizzy in the past. So, trade-offs.
And physically. Any limitations there?
Yes, significant ones. His mobility was really limited because of spinal stenosis, that's a narrowing in the spine.
Puts pressure on nerves.
Right. And hip pain, probably arthritis, he could only walk about 20 yards.
20 yards, that's not far at all. That really impacts daily life.
Hugely. But let's circle back to that positive point you made earlier.
The family support.
That robust social support, as the source calls it. His son and daughter sound incredibly switched on, engaged, asking questions, trying to figure out the best way forward.
They're clearly a massive asset here.
Absolutely. And knowing about that support helps frame the underlying goal of the care plan, right?
Which is?
Well, it seems to be treat the myeloma, get it under control if possible, but do it in a way that carefully manages and minimizes the risks from all these other health issues.
Finding that balance.
Exactly. Balancing fighting the cancer with protecting his quality of life, his ability to function day to day.
Makes sense. The source lists the key meds they discussed too, right?
Let's see. The Exelon patch and Memantine, those are for the Alzheimer's. Bupropion for depression. Mirtazapine, which he'd taken before for mood, sleep, appetite. And Maribigron, that's Myeloma for the bladder issues.
And some he'd stop, like fluoxetine and oxybutynin.
Right. And if you look at his whole medical history together, Alzheimer's, the myeloma that's now active, the chronic depression, spinal stenosis, osteoarthritis, hip pain, anemia, probably from the myeloma, some kidney function worries, the urinary incontinence.
It really paints a picture of the total health burden he's carrying.
It absolutely does, a complex picture.
Okay, so that's the background, the family's view, his history. Now, what did the doctor find? The objective stuff in the geriatric assessment.
Well, a lot of it confirmed and kind of quantified what the family reported. Functionally, yes, that limited mobility 20 yards was noted.
Right.
And the assessment was that he likely needs help with what we call instrumental activities of daily living.
So not just basic washing and dressing, but things like
managing money, managing his medications correctly, remembering appointments, maybe complex cooking, things that require more executive function.
And that's mostly due to the cognitive issues.
Largely, yes. The assessment confirmed Alzheimer's diagnosis, noted significant short-term memory problems, the need for repetition.
Did they notice his distress about it?
They did. The source mentions he was distressed by his own deficits, and it noted those fluctuations in clarity and brought up that powerful example again about not recognizing his brother. It clearly made an impression clinically, too.
And his mood.
Confirmed the chronic dysthymia, and yes, he was showing depressive symptoms even on the bupropion. And the chart noted the family's report about mirtazapine potentially helping in the past.
Okay, and the medication situation. The polypharmacy.
Clearly flagged. He was on at least 5 psychoactive or neurologically active medications, plus others. And just as the family suspected, Myeloma, with its anticholinergic side effects, was specifically noted as a potential contributor to cognitive issues.
So the family's instincts were spot on there.
Seems like it. The rest of his medical history, as we listed, Alzheimer's, myeloma, depression, spine, joints, kidneys, bladder, it just reinforces the overall health burden.
Did they look at nutrition?
They did. Noted his appetite seemed better on mirtazapine previously, but there was some prior weight loss during the pandemic, so it's something to keep an eye on.
And the social support.
Rated as excellent, a definite strength, a real positive in his corner.
So pulling all that together, the clinical findings, the history, what was the overall assessment of Mr. B's condition, his sort of general state?
He was assessed as being pre-frail to frail.
Pre-frail to frail. What does that mean in practical terms?
It means his physiological reserve is diminished. He's more vulnerable to stressors like illness, or in this case, intensive cancer treatment, than a robust, older adult would be. He doesn't have the same capacity to bounce back.
Okay. Which leads us right back to the core dilemma, doesn't it?
Exactly. The million-dollar question.
Is this 82-year-old man with Alzheimer's, depression, frailty, mobility issues, polypharmacy, is he actually a candidate for this pretty aggressive myeloma treatment?
And this is where the nuance comes in and why geriatric oncology is so important. The answer from the specialists was yes.
Yes.
Yes, he is a candidate because his myeloma has progressed and warrants treatment by UT. And this is the crucial part.
Here comes the but.
A very significant but. He is considered to be at very high risk for treatment-related side effects, toxicity we call it, and also for functional decline, losing ground physically or cognitively.
And that high risk is directly because of all those vulnerabilities we just talked about.
Precisely. The Alzheimer's, the mood issues, the polypharmacy, the frailty, they all stack up to make him much more susceptible to the negative effects of the cancer drugs.
Okay, that makes sense. He can get the treatment, but it's like walking a tightrope because the risks are so much higher for him.
That's a good way to put it.
So let's break that down. How exactly does each vulnerability increase the risk? Let's start with the big one. the cognitive impairment, the Alzheimer's.
Okay, well, think about it. His Alzheimer's fundamentally impacts his ability to participate safely in his own care. One of the myeloma drugs, lenalidomide, is an oral pill.
Revlimid, yeah.
Taking that correctly on the right days, not missing doses, not double dosing, when you have significant short-term memory loss. That's incredibly challenging, if not impossible, without help.
So adherence is a huge issue.
Huge. It also affects his ability to notice and accurately report side effects. Is he feeling more tired, more confused, having new pain? He might not be able to articulate that clearly.
Which means treatment really hinges on the family.
Almost entirely. They become responsible for managing the meds, watching him like a hawk for any changes, and you absolutely have to educate them about potential cognitive side effects from the treatment itself.
Especially the steroids.
Especially dexamethasone. It's notorious for causing confusion, agitation, even delirium in vulnerable older adults. Caregivers need to know what to look for.
Okay. And his depression. How does that play into the risk?
Well, dexamethasone can also worsen mood, sometimes dramatically. So his existing chronic depression is a risk factor for that.
Making it potentially much worse.
Potentially. And if his depression isn't well controlled, it affects everything. His motivation to stick with the treatment plan, his overall quality of life, and again, his ability to report symptoms accurately. Is he fatigued from the chemo or from the depression? It gets blurry.
So managing the mood is critical for the cancer treatment to even work well.
It really is. Continuing his bupropion, monitoring him super closely, especially when he gets those steroid pulses, and keeping mirtazapine in mind, maybe tweaking the dose if it seems like the benefits for mood, sleep, and appetite could outweigh the dizziness risk now.
Okay, polypharmacy. Adding potent cancer drugs to an already long list sounds tricky.
It's a minefield, a major, major challenge. Adding the myeloma drugs, especially dexamethasone, which has tons of interactions and side effects itself, dramatically increases the risk of drug interactions and just the cumulative burden of side effects from everything combined.
Like that Myrbetriq for the bladder.
That's a perfect example. Its anticholinergic effect could worsen cognition. Adding dexamethasone, which also can affect cognition, plus potentially other drugs, you see the problem.
That stacks up fast.
Very fast. It means the team has to do a really careful, thorough review of every single medication he's taking. They need to ask, is this drug absolutely essential? Is the benefit worth the risk in this context now that he's starting chemo? Could Myrbetriq, for instance, be stopped or switched to something less likely to affect his brain?
That's where deprescribing comes in, right? Taking things away.
Exactly. Actively looking for opportunities to stop medications that are no longer needed or where the risks now outweigh the benefits for this specific patient at this specific time.
And his physical limitations. The frailty, the walking difficulty.
That's another key vulnerability. Myeloma treatments often cause fatigue. Some can cause peripheral neuropathy nerve damage in the hands and feet, causing pain, numbness, weakness.
Which could make his walking even worse.
Easily. Much worse. So it's vital to get a really clear baseline picture of what he can do physically before starting treatment, what's his usual level of activity, how far can he really walk, and then you need a very low threshold to call in physical therapy if you see any decline.
Prevent things from spiraling downwards.
Try to, yeah. Maintain function as much as possible.
But that strong family support we talked about, that acts as a buffer against some of these risks.
It's more than a buffer. It's an essential component of the management plan. It's because he has that support that managing this complex treatment at home is even feasible.
They are the ones doing the day-to-day monitoring and medication management.
They are the front line, giving the pills correctly, watching for side effects, providing emotional and practical support. Without them, this whole plan would look very different, or might not even be possible outside of a facility.
So the overall assessment holds. He can be treated, but it's definitely not straightforward care.
Not at all. It demands extreme caution. It requires really intensive co-management, the cancer doctors and the geriatric specialists working hand in glove.
Constantly weighing things up.
Constantly. Is the potential benefit of shrinking the myeloma worth the very real risk of the treatment causing harm, tanking his quality of life, or making him physically weaker? It's an ongoing calculation.
Which underscores why that shared decision-making piece is so critical. Involving him, involving the family.
It's paramount. You have to understand their goals. What matters most to Mr. B and his family at this stage of his life? Is it longevity at all costs? Or is it maintaining independence or cognitive function or comfort? Those priorities have to guide the treatment choices.
Okay, so given this incredibly complex situation, all the risks identified, what was the actual plan? The blueprint for moving forward that came out of this consultation?
All right, the plan essentially said, yes, proceed with the planned cancer treatment.
The lenalidomide, dexamethasone, daratumumab?
Right, but, and here's the key, with very close oversight and active co-management from the geriatric team alongside oncology.
So not just a one-off consult, but ongoing involvement.
Exactly. Geriatric co-management was the core strategy to try and head off those risks we just discussed.
What concrete actions did that involve? What tools did they use?
One really practical, vital tool they gave the family was a daily monitoring log.
Okay, like a diary.
Sort of, but more structured. It prompted them to specifically track key things linked to his vulnerabilities every day. His cognition, mood down, anxious, sleep, appetite, urinary symptoms, pain levels, and any new or worsening problems.
So the doctors get real-time data from home.
Precisely. It helps catch subtle changes early before they become big problems. Hugely important given his communication challenges.
Smart. And what about managing that medication list? Optimizing things.
That was a major focus. For mirtazapine, they decided to continue it at the 15 milligram dose he was on, nightly. They talked about maybe increasing it later for mood appetite, but decided to hold off for now, see how he did with the cancer drugs first.
Okay.
For Myrbetriq, the bladder drug with the cognitive concerns, the plan was proactive reevaluation. They discussed the anticholinergic risk with the family. The idea was, let's see if he really needs it. If his cognition worsens, they'd look hard at stopping it or switching to something safer for the brain.
And the dexamethasone, the steroid. How are they managing that beast?
Proactive education was key. They spent time explaining the likely side effects to the family, specifically. Mood swings, insomnia.
Recommended taking it in the morning for that.
Exactly, morning dosing to minimize sleep disruption. Also warned about high blood sugar, hyperglycemia, muscle weakness, and increased infection risk. Forewarned is forearmed.
And the general medication list.
Ongoing vigilance. The plan included regular review of all his meds throughout treatment, constantly asking, is this still needed? Is the risk worth it? Actively looking for chances to deprescribe.
So managing the Alzheimer's and depression wasn't separate, it was integrated right into the cancer plan.
Absolutely. Fully integrated. Cognitive support meant reinforcing caregiver strategies for managing the Alzheimer's day-to-day, making sure the medication schedule was foolproof.
Right.
Mood management meant continuing the bupropion, watching his mood like a hawk, especially during steroid wints, and having a plan B, like involving psychiatry quickly if things went south.
And addressing the physical side, his mobility.
Yeah, encouraging him to stay as active as he could tolerate. Specific advice on preventing falls, which is a huge risk when you're frail and maybe dizzy from meds. And, as we said, being ready to jump in with physical or occupational therapy if his function declined.
Any other specific issues tackled in the plan?
Yes, they noted the need to monitor his kidney function closely via the routine cancer blood tests, and really stressed keeping him well hydrated. Also, they ordered that MRI of his hip to get to the bottom of his pain.
It really sounds like a huge part of this was educating and empowering the family.
Fundamental. They didn't just get a plan, they got an explanation. The source says they had a deep dive into how aging, myeloma, and the treatment all interact. They understood why the monitoring log was so important, why open communication was crucial. They were given a written blueprint summarizing everything.
So they became real partners in the plan.
That was clearly the goal, and the follow-up reflected that too. A formal geriatric oncology telehealth visit was scheduled for 2 months later, but crucially, the family was empowered to reach out much sooner if anything changed or worried them. No waiting for the appointment. And ongoing, close coordination between the geriatric team and the main cancer team was baked into the process.
Okay, let's pull back then. We've gone deep into this specific case. What does it all mean for you listening to this? Maybe you're facing complex health decisions yourself or helping someone who is. This case really crystallizes some key insights from the source material.
It really does. I think the first big takeaway is you simply cannot treat a serious illness like cancer in an older adult in a vacuum.
Right. It's not just about the tumor.
Not at all. You have to consider and actively manage how it interacts with those common issues of aging, the geriatric syndromes like cognitive decline, frailty, polypharmacy. They're not side issues. They fundamentally change the game.
They impact tolerance, side effects, outcomes.
And everything.
Everything. Second big point, you need to be proactive about managing potential side effects, especially with drugs like steroids or chemo that have known risks.
Exactly. Knowing the patient's vulnerabilities allows you to anticipate problems. You can educate, monitor, have backup plans before a side effect becomes a crisis. It's preventative management.
Third point seems to be about the family.
Oh, absolutely. Engaged family members like Mr. B's son and daughter aren't just helpful bystanders. They are essential, invaluable partners in care.
And giving them practical tools makes a difference.
A huge difference. That monitoring log wasn't just busy work. It was a critical safety tool. It empowers caregivers and gives the clinical team vital information they wouldn't otherwise have.
And the fourth key insight.
Shared decision-making. It sounds simple, but it's profound, making choices together based on a really clear understanding of the risks, the potential benefits, and crucially, what matters most to the patient, their personal goals, their priorities for quality of life. That has to be the foundation.
So the medical plan actually serves the person, not just the disease metrics.
That's the essence of it. This case is just such a powerful illustration of what that kind of comprehensive, person-centered geriatric oncology care looks like in the real world.
It really is. And this whole deep dive, it really shows that just treating a disease, well, that's only part of the picture, isn't it? Especially as we age. It kind of leaves us with a bigger question, maybe something for you to think about. How can we, as patients, as families, as a healthcare system, get better at empowering people to be true partners in navigating these super complex health decisions?
Yeah.
How do we make sure that the plans we make don't just focus on the diagnosis on the chart, but truly honor the whole person, their story, and how they want to live their life, whatever challenges they face?
That's a goal, isn't it?
It really is. Thanks for exploring this complex but vital topic with us today on The Deep Dive.